Welcome back. I'm Dr. Larry Kaczynski, one of the PTAC members. In our second session this afternoon on lessons learned from state value-based care models that have implemented multi-payer alignment, we will hear from 4 distinguished experts who will discuss the multi-payer models in Pennsylvania and Arkansas. You can find their full biographies and slides posted on the ASPE PTAC website and the public meeting registration site. At this time, I ask our session participants to go ahead and turn on your video if you haven't already done so. After all 4 experts have presented, our committee members will have plenty of time to ask questions. First up, we're happy to welcome back Ms. Janice Walters, who is Chief Executive Officer at Rural Health Redesign Center. Great to have you back, Janice.
Thank you so much. I count it a privilege whenever I get to speak on behalf of the work that we've done in the state of Pennsylvania. So really appreciate the opportunity to be here. So thank you for the invitation. So yeah, hopefully just gonna hit on some high level key lessons learned. I've been informed that most of the members are familiar with the program, so I'm not going to spend a whole lot of time talking through the specifics, but really focus on lessons learned and some other things we're learning here at the Rural Health Redesign Center specific to rural health, payment reform, and what it takes to be successful in those regards. So if you could move on to the next slide, please. Short bio. I'm not one that likes to see their picture on slide decks, but certainly, have spent the majority of my professional career leading some rural health innovation. Healthcare is my third industry. So one of the things that I feel like I bring to this work that is unique is I'm not a lifelong healthcare professional. I have other industry knowledge that I bring to the table. So when I think about some of the problems that we're trying to solve as it relates to rural health and even just broader payment reform, population health and wellness, really understanding the role that healthcare plays within the macro system, and how interdependent healthcare really is, and how the broader system really is dependent. And so I bring that industry lens, bringing in manufacturing, communication, and then healthcare, and really take a systems approach to the work that we do here at the center. If you go on to the next slide real quick, who we are, the Rural Health Redesign Center. Our mission is really to protect and promote access to high quality healthcare in Pennsylvania as well as the nation, all with a vision of really helping rural communities thrive. As I just stated in some of my opening comments, healthcare is just vital to broader economic development. And ensuring that that access stays in the community is fundamental if we want to have thriving rural communities. So that's really our vision, is to use our knowledge to help rural communities thrive. And our team is actually made up of a number of individuals. We have over 40 individuals, plus a lot of wonderful technical partners that help us do the work here at the center. And we most recently did a survey, and while we're saying our team has over 200 years of combined rural relevant experience, based on our team right now, that number is 500. So really, we collectively have over 500 years of experience in dealing with rural health issues specifically, working with just wonderful industry leaders that know what it takes to run rural healthcare organizations boots on the ground, and what type of change is effective and what type of change is not. Part of the creation of the Rural Health Redesign Center, I just wanted to hit on this point. It really was part of the CMMI demonstration. So the Pennsylvania Rural Health Model, which is certainly the flagship program that I've helped run here at the Rural Health Redesign Center, really was a partnership with CMMI and the Commonwealth of Pennsylvania. But part of that model, the Pennsylvania Rural Health Model, called for the creation of the Rural Health Redesign Center, specifically really hoping to create an entity that could be leveraged to serve as a technical assistance center, not only for Pennsylvania, but really the country. And so part of the vision of our work was understanding what works with rural health innovation specifically, and then being able to use that, create an entity that could then be leveraged and serve as a technical assistance organization for the country through consultative arrangements. So it's been just wonderful pleasure and highlight of my career to be able to lead such groundbreaking work, not only on behalf of the state, but really the country, and see this organization come to life. And certainly that was before the RHTP happened last year, but really to just see this organization come to life and bring to purpose, creating a center that we can take lessons learned so that other states pursuing and other organizations pursuing similar interests don't have to make maybe the same mistakes we did, but can get to better solutions quicker. If we go on to the next slide, please. So real quick, the Pennsylvania Rural Health Model, acronym PARM, really was looking to achieve three things with two pillars, two objectives. And so really we were looking to improve rural hospital financial viability or stability, improve population health outcomes of people that lived in those communities that the hospital served, and then reduce the total cost of care over time. And we had two mechanisms within our program to really achieve that. And the first was the global budget, paying hospitals a fixed payment to provide predictable cash flow, and then ask them in exchange for that predictable cash flow to put together transformation plans that really the goal was moving away from volume to a value-based delivery system. If we go on to the next slide, please. Just some data to show that within the program, we were able to reduce potentially avoidable utilization. So that was one of the mechanisms, and one of the things that we were trying to do is provide the right care in the right setting. And so we do have data that shows that over the course of the program, for most of our hospital and payer relationships, we actually did indeed reduce avoidable utilization over the life of the program. And just like to note that there was a pandemic in the middle of all of this. And so the fact that we could actually achieve these objectives and manage through the pandemic was certainly noteworthy. The most important thing, if you go to the next slide, though, is really what we've learned from the demonstration. And so while nationally you might hear that the Pennsylvania Rural Health Model, or publicly you hear that the Pennsylvania Rural Health Model is sunsetting, it's coming to completion, the work does continue here in the state of Pennsylvania. And so I continue to work with the payers that were part of the first program and many of the providers and the hospitals as well. We've expanded that stakeholder base to say what worked well, what have we learned, and where can we make improvements and really iterate on what we call a next generation strategy. So the program really provided a robust learning laboratory for what worked and what didn't work within rural APM structures specifically, because again, ours was a rural only model. And then now we're really iterating on that to take that into the future to say, okay, how do we continue to iterate and build a next generation program? So that's the work that I'm currently leading in the state of Pennsylvania, is really iterating on the first version with the goal of getting a next generation program off the ground. Transparently, we don't have CMS at the table right now, but we felt the work in the state of Pennsylvania was too important that we have to keep going on it. And hopefully we'll be able to figure out a way to get CMS back to the table as a partner with us in this work. But some of the most important things that we've learned, relationship and trust, stakeholder alignment is fundamental if we want a change to happen. We need, in addition to payments, alternative payment, we need broader infrastructure, and of course, really need good planning. I like to say this work is really hard. If it were easy, it would have been done. But the fact that our stakeholders are staying at the table to really continue to iterate and move forward, to me, is a huge win, a huge lesson learned as well. If we go on to the next slide, some of the overarching things that we've learned from, again, the first Pennsylvania Rural Health Model, the experiment, as I like to call it. As we think about a next generation program, what do we actually need? And one of the things, first and foremost, it's got to be palatable for both our payers and our hospitals. Provides the right care within the local community. So one of the things that we're not sure the first program did was actually preserve the right care in each community. So we're spending a lot of time defining essential services. What does essential service actually need? Where do these services need to be provided? And something that can be customized at the local community level. We know it has to take into consideration costs. So the first program was revenue only, and that's created some issues in an extreme inflationary period. So figuring out how to bring cost into the equation, something that provides truly predictable revenue. So some of the ways our program was administrated, undermined the predictability that we were trying to achieve. And so really getting to predictable revenue, and is easily understood by program participants and reduces administrative burden. Those last two really being informed by, we built a pretty heavy, cumbersome program. And so are there ways to get to the ideal end with less burden? If you go on to the next slide, the other thing that I wanted the committee to know about that, in addition to the Pennsylvania Rural Health Model, we also are working with hospitals that are pursuing the Rural Emergency Hospital designation, so the new CMS licensure. And really, again, it's a step in the right direction in terms of changing payment for rural hospitals. And that fixed facility payment that the rural emergency hospitals are now receiving, has really first stabilized cash flow, providing predictable revenue, getting some of those hospitals to sustainability. So while we've worked with over 200 organizations, to assess the feasibility of that licensure, only around between 45 and 50. So there's always, that number's always changing as we continue to work. But I think the last publicly reported number was 44 hospitals have converted because the math worked. But the cool thing that I wanted this committee to know is that these, through the alternative payment, through that fixed payment within the REH space, we do see some of the hospitals, the early adopters, moving into population health and wellness and really starting to use that fixed payment in a different way. And so to me, that's exciting, because once hospitals have a different payment mechanism, we've seen them step into the population health and wellness. And I just wanted to share that as an example of alternative payment working. If you go to the next slide, please. So just to wrap it up, this is really, really hard work. If it were easy, like I said earlier, if it were easy, it would already have been done. And so some of the things that it takes in order to achieve such broad sweeping innovation, relationships and trust is certainly in the middle of all of that. Building relationships with the stakeholders, understanding that we're all pulling in the same direction and aligning on purpose, and then the leadership skills that it takes. And so just listing on this slide for you some of the key things that, from my experience and those that I've worked with within the program, what it really takes to do this type of work. Perseverance, tenacity, humility, honesty and communication, alignment of purpose. There's a lot that goes into that, but more importantly, it takes time. This is a marathon, not a sprint. And so again, I just thank you for the opportunity to be here. Next slide is contact information, but we're really excited about the work that we've done in the state of Pennsylvania and where we're taking our next generation program. And again, back to who we are as an organization, I really do see us as the puzzle piece in the middle that holds it all together. We're a neutral convener. And so in order for any APMs or alternative frameworks to work, you've got to be able to get all of the stakeholders together and get that alignment of purpose in order to move forward. So that's my final comment. And again, thank you so much for being here. And I just look forward to the conversation.
Thank you, Janice. We're saving all questions from the committee until the end of all presentations. Next, we are pleased to welcome Dr. John Bulger, who is the Chief Medical Officer at Geisinger Health Plan. Welcome, John.
Thank you, and thanks for having me. It's great to be back and talk to the group and I think really talk about something I'm passionate about and we've been passionate about in Pennsylvania and give you my perspective, at least as one of the payers involved in the Pennsylvania Rural Health Model. Next slide. She can go 2 slides. This slide kind of just gives you a little bit of bio on me. If you look at where we've been over the last 10 years, and it has been, and Janice talked a little bit about it, it has been a journey. It's interesting for me because Geisinger's been involved in this both as a payer in Geisinger Health Plan and as a provider. So one of our hospitals, a rural critical access hospital in Jersey Shore, Pennsylvania, which is not on the Jersey Shore. That probably story another time. Has been involved in this model since it started. And Geisinger, we were very committed to that, really because we're committed to the communities we serve and making care better in rural Pennsylvania. But it has been a journey, and there's been just so many different lessons learned as we went through that. We'll talk a little about some of those today. Next slide. The what is the value proposition? And I think that's a question, and I'll hit on that a few times as we go through this. I think first and foremost, it's about access to care. And these value propositions really align across whether you're a hospital or a payer. The hospitals are there really to provide care in these communities. And as a payer who serves these communities, one of the biggest things we're focused on is making sure our members are able to get care in those communities. So I think it's first and foremost access to care. And then you roll into the other ones, population health, and being able to really think about what does the population need. I think population health is one of those terms that gets overused a lot, but I think about it in this sense is what's needed in those communities, not necessarily what some want to have in the communities, not necessarily what do those communities have to do to pay for or bring in the dollars to get care in those communities in a fee-for-service system, but what's needed, what is needed in those communities, and what services do we want to get? So that's the population health piece. It is important to remember that many times in rural communities, in all states, it's certainly that way in Pennsylvania, healthcare and the hospitals in those communities are the economic engine. Many of these communities have had decreases in their manufacturing base and other bases, and it's the hub of the communities, the hospital. It's the people who work in the hospitals. It's the people that drive that come into the hospitals and use other services in the community. And it's what those hospitals give back to the community. So keeping them alive and vibrant is extremely important. And in the end, we want to be in a learning health system. We want to be able to test and take away and understand what's happening. And that's really the other piece of this value proposition. As Janice said, a lot of this is a great unknown. It's not like there's a playbook out there that you can Google and say, how do we keep rural hospitals thriving? It's on the tip of everybody's tongue from a policy standpoint. And a lot of what we've done with this program and a lot of what we'll continue to do moving forward is really trying to collectively learn so that we can make things better for future generations. Next slide. So what are the things that were required in transformation plans? And I think, one of the, why does a payer do this? The payers did do this because one, when you're taking risk from a payer standpoint, the more certainty you can have, the better the process is. So this created the global budget model, created a lot of certainty around what the payments were going to be and how we were going to work with the payers. We also want better outcomes, and we want to try to find ways to have better communication between the payers and the providers. And one of the hooks that's part of this is from a payer standpoint, we'll change the payment model. We'll give upfront payment and have that knowledge, but at the same time, we want to do something different. And that was what the transformation plans are about. What you see is there's some things that, care management, this whole notion of how do we get services in the community to help the most vulnerable in the community. You see access being the second one, but then you see kind of this, and I just highlight ED utilization, which would probably be on the tips of all of our tongues. But then the areas like social determinants of health, substance abuse, behavioral health, those are things that we know are lacking in, quite frankly, all communities. But in rural communities, it's really tough to get those things to exist and then to thrive. And those were areas that were being neglected, but because of the transformation plans, because of this program, we were able to get the hospitals and get the payers to be talking together as to how are we going to change those things in the communities. And really this hook of saying, okay, we're going to stabilize things, but we also need to transform. We're not just going to stabilize things and stay the same. Next slide. So, this and Janice kind of connected on this of saying aligning on the purpose, but and this was really the purpose we tried to align on is, trying to preserve the right care for rural communities. And the global budget was a vehicle to do that, but it's only one vehicle, and it was the vehicle we were using. But I think one of the biggest take homes was, and you'll see it in further slides, is this piece of collaboration. You can go to the next slide. And it's interesting because when you look at, we did a survey and said with the payers and the hospitals and said work well and what needs improvement. What's interesting is the top in what worked well is communication between hospitals and payer. And the second one in what needs improvement is communication, hospitals, payer. And it's one of those things where I think there was a generally felt to be a lack of communication perceived on both ends, both hospital and payer, when we started this. And that increased a lot as we went through the program. But as you might expect, the more that you get of that, the more we were communicating, the more we wanted to communicate. We wanted more of that good thing we were creating, which is why you see that on both these. I think a great piece of this is that every hospital that was involved in this from the beginning and further is still providing care to patients in Pennsylvania. And we all know the statistics on rural hospital closures. And to me, when people ask me what was the biggest success with the program from overall, but from a payer standpoint, it's that none of these hospitals had to close. They're all still able to be vibrant parts of the community they're in. But you also see in this that there's some lessons learned that we need to take to the future. So the budget methodology, even though it's somewhat standard, it is, anytime you need a kid to people at the health plan, anytime you need an actuary to help you with something, you probably have a barrier to overcome. And, the reality of the way the budgets worked, and, in spite of all the awesome work that Janice and her team did, it does create a little bit of, I'd say, angst with the people working with it. And that's why that's number one. You see the other things that were the needs improvement were, much smaller in that standpoint. Next slide. So, as Janice said, the thing we're working on moving forward is what it's going to look like in the next generation. And we're lucky to have attendance between hospitals and payers. We're lucky to have our state involved, and we're lucky to have other interested partners that want to look at this moving forward. But, I'll finish just with saying the things we're focusing on. Why are payers want to do this? Again, it's the certainty. We have seen better outcomes as a payer with this, and it really has brought everyone to the table. And I don't think we've seen payer collaboration in Pennsylvania outside of this in the same way we did in the rural health program. And we haven't seen collaboration between the payers and any hospital community, whether it be rural and urban, but this program has brought them together. I think on the provider side, it's provided stability for those providers. It's allowed them to do things that they've wanted to do, but weren't able to do, because if you're in a fee-for-service system and your survival is a reality, is a problem, then you have to go do the things that fee-for-service gets you. And many times we did a survey to say, if you look at what rural hospitals to do versus what they want to do. What you see, what they do are the things that they get paid more from a fee for service standpoint. What they want to do generally are the things that are on that list in the transformation model, things like care management, things like substance abuse, behavioral health, SDOH, palliative care. There's that mismatch there. And what this program did is it let the hospitals survive, but still be able to do the things they want to do. And from a payer standpoint, those are the things we want to do as well. So there was just this kind of alignment of purpose was incredible with the program. Next slide. So that's the end of my talk, but I'm really excited to continue the discussion and answer questions as we move forward. Thank you.
Thank you, John. Next, we are excited to welcome Dr. Dawn Stehle, Director of Early Childhood Systems Policy and Planning at 0 to 3, and Ms. Alicia Berkemeyer, Executive Vice President and Chief Health Management Officer at Arkansas Blue Cross and Blue Shield. Please go ahead, Dawn and Alicia.
Thank you, Larry. Appreciate that. I'm very excited to be here today to speak to the group, especially for the fact that I've heard so many similar and repetitive consistencies of today around this value work. So in my regular job, I day-to-day work with the medical management provider networks, certainly our pharmacy and health economics, but really have a passion around value-based care. And as you'll see here today, Dawn and I, in our typical collaboration across the state of Arkansas, we are going to talk about this Arkansas value journey together because it is a journey. I think what has been said by Janice recently is about finding that common interest, that common passion, and ours is really improving healthcare in Arkansas, and we're excited to tell our story. Dawn, I'll pass it to you.
Thanks so much, Alicia, and thanks so much, Larry, for the warm introduction. Rarely do people pronounce my last name correctly, so I just want to just give an extra special thank you for that as well. But just excited to be here with everyone today, and as Alicia said, tell you a little bit about our story. You know, we really felt like it was important that since we started this journey together and we've continued on this journey together, that we actually share then the story of our work together. So as you may have noticed, I am currently with 0 to 3, but I want to talk a little bit about like the work I did with Alicia and many of our other partners when I was with the Arkansas Medicaid program, of which I served as the Medicaid director for 8 years. So excited to be here today and talk to you a little bit about our journey together. So if you would, next slide, please. Before talking a little bit about how we got here, we thought it was helpful to talk a little bit about sort of who we are and a little bit about the state of Arkansas. Because I know many people, when they think about Arkansas, they probably think about rolling hills and lots of rivers and streams. And while we have lots of those as well, we also want to talk a little bit about the people, because at the end of the day, that's what this is about. It's about the people that we serve and our neighbors and our fellow community members. So in Arkansas, we have a little over 3 million people. As you may not know, we are a popular destination for retirees. So as you can see, we have almost 20% of our population is actually over the age of 65. And so that's definitely something we have to think about in terms of the healthcare system. On the other end of the spectrum, we actually have just over 20% of our population is actually under the age of 18. So as we think about, you know, sort of what the landscape looks like, we have to think about both our youngest as well as our oldest, and of course, all of us in between as well. Arkansas is a very rural state by definition. That said, we have about 72% of our counties that are actually considered rural, but when you look at it, about 44% of the population actually lives in a rural area. Taking a minute to focus on some of the economics for a second, we are slightly above average in terms of when it comes to the percentage of individuals living below the poverty level. Compared to the United States, we were at about 16% of the population that actually meets that criteria. And then along with that, we also thought it's helpful just talk a little bit about sort of what our primary care landscape looks like. So as you can see from the map there on the right side of the screen, we are a area that has a lot of things going for us, but one of those is that we are actually a primary care shortage designation area, which means, as you can see from the picture on the screen, we only have about 9.4 active primary care physicians per 10,000 residents. So that's definitely something that helped to inform our journey, which I'm going to turn to Alicia on the next slide to talk a little bit about what this means for us and and helping think a little bit about the landscape of how we got here.
Thank you, Dawn. The fun in this is we do get to tell the story, and our start of this is quite interesting. We are a state that was agreed upon that the governor at that time, Mike Beebe, came to Dawn's boss at that time, John Stehle, and said that healthcare is not sustainable. We've got challenges in Arkansas, and we've got to look for some answers to fix this. At the same time, he came to my boss, Mark White at that point, our CEO, and said the same thing. I think that set us on our journey from the public and private sector that I think after that point, we met at least weekly, if not more often. And very quickly, we decided that it doesn't matter if it's Arkansas Blue Cross, it didn't matter if it was Centene or at that point, Qual Choice or Medicaid. We were trying to accomplish the same things. We needed a better, healthy state. We needed better care for Arkansans. And so from that point on, and we in this model here showing that we really truly joined hands and became lockstep in trying to improve healthcare. If you go to the next slide, this is the fun slide to talk about. This, we call it our building blocks of value, because it truly is a journey. It takes time and it's very hard. And those are all things you've heard today about these challenges. But I'd like to, first of all, point out the color coding on here. So the dark blue here are two initiatives that were strictly just Arkansas Blue Cross and Blue Shield. And from an Arkansas Blue Cross journey, we started in 2010 when my boss came to me and says, what is a patient-centered medical home and how do they work? So we started a pilot, and I brought on 2 vendors, and I thought, well, I'll have one with the transformation support, one with the data support, and then we're going to make magic happen. I wish I could tell you that in 2026 that magic was happening, but I learned a lot of things. And even though we're one of the larger payers here in the state of Arkansas, practices said, number one, Arkansas Blue Cross, if you're going to do that, you've got to be here by our side. But number 2, you can't pay me enough to change my entire practice and to support those changes needed. And that's where we were very fortunate to come into the play of CPC. The Comprehensive Primary Care Initiative really allowed us all to lock hands, to come together, to really join in quality measures and metrics and really have some amazing outcomes. From there, and I'm sticking on the column here of the primary care, then we moved into the statewide or patient-centered medical home that basically the 2 red ones are things that are still in place, active today. And the patient-centered medical home, what's so important in that is to be a payer on our marketplace in the state of Arkansas. Medicaid has defined what those medical homes are and how we have to support and reimburse them. So we're all aligned in that state effort. Then we moved into the CPC Plus and the primary care first models. Going back to 2012, when Dawn and I started those regular meetings, it truly was the episodes of care. And those are where we aligned in our reporting systems and other things that were very, very important to us. Dawn, do you want to talk a little bit about the episode work? Because that really was our starting together.
Absolutely. Yes, it was pretty novel at the time when we started down this pathway. I think that people kind of question like what what it was and what it could do, and we really saw it as really sort of our first sort of entree, if you will, into the world of value-based purchasing. Not that we hadn't been doing things before, but really I think in terms of trying to sort of all point in the same place. That's one of the things I love that Janice said, and kind of talking about some of the work in Pennsylvania, was we recognize that if we were going to do this, we had to be able to do this in a way that providers felt like that they really were engaged in the process, but also that we as a payer community were all sort of pointing towards the same values and incentives that we felt like were so important. And so that really was sort of the kickoff to us being able to kind of come together with the providers, with patients, and with other payers to really think about sort of what these could look like, and really thinking about sort of where we had the most opportunity for value within the system. And so that really kind of led us on our journey of thinking about sort of those sort of condition-specific type opportunities versus things that were more focused on sort of chronic care or overall health and wellness in general. So, but that was a little bit about our episodes of care work.
Thank you, Dawn. I think throughout all of these programs you see here on our map today, we really worked hard as a state to align in our quality measures, our data and reporting to the practices, and the attribution. So really coming up with common definitions to support this work was so very important for us. I think all payer claims databases played a big part into that, as well as our HIE. We also carried this work through the State Innovation Model support, a State Transformation Collaborative, and the Multi-Payer Healthcare Expenditure Dashboard. Dawn, would you like to add anything about that or any of the others that I've covered?
No, I thought you did great. Thanks, Alicia.
Okay. Well, what we'll talk about here on the next slide, we're going to talk about one of the keys I think that's been very important for us and very successful is our state health information exchange. We are very fortunate that we have one in our state, and our HIE sits underneath the Arkansas Health Department. I think with that model, through our value programs, we have encouraged and really supported and driven data through that, as well as some, in order to be a patient-centered medical home practice in our state of Arkansas, you had to sign up for our HIE. We have well over 95% of the hospitals that are signed up through the HIE, and also from a payer perspective to participate in some of the value work and through our exchange and things of that such. We've really tried to get as much as we can to the practices. So the admission, discharge, and transfers, the information about with the hospital discharge and things like that has been so very important, not only to the practices, but for example, our case managers, our nurses as well receive that information. So really looking at use cases and driving that information. Next slide, please. This is another little bit example of just the roster. So we as payers submit our attributed lives to the HIE, then we get the information back. And this prevents, initially we had started where the practices were having to submit that. And then we moved into all the payers. Now we do that on behalf of the practices because some of those small rural practices really struggled with that. So trying to simplify the process to make it really successful for all of us. So we can go on to the next slide. Because one of the things that I'm very proud about is because of being a state utility, we actually have had many uses for this. So this is just an example of the hospitalization reports that those care managers receive every morning. We also used it during COVID. So very quickly, because we already had this utility in place, our nurses, the nurses in practices had that information, could understand when beneficiaries are losing coverage. We do some outreach and collaboration, and also some foster home children to be able to have consistent care if they're in and out of different homes. Another key project through the HIE is really immunizations. And you probably all are familiar with that sometimes we have some trouble with having baby 1 or 2 or girl or boy, and then we kind of get a name. And so we've really done a lot of work through that and trying to clean up our data and coordinating the HIE as well as the all payer claims database. Next slide, please. I think on the foundation, you'll hear the message that we try to go through this is really looking at the patient. How do we put the patient at the center of all the decisions we make around this care and collaborate around that patient? Next slide, please. And as Dawn talked about, people like to retire or like to visit Arkansas. So many of these pictures are to entice you to come visit us in Arkansas. We'll take you to any rural practice or any place you'd like to see. One of the keys to our success has certainly been collaboration and coordination. I think that is something that we are very proud of. And this is a picture of an example. One of the key stakeholder meetings that really made a difference and an impact on some of these wins we've had was in 2017. This was at the Arkansas Hospital Association. And you'll see that it included the payers, it included employers, as well as some patients at the table. And that was one of the things that I certainly learned when we started our patient advisory councils, trying to how do we onboard patients, because we circled through a few patients before we could get them to feel comfortable in that environment to really speak up and help us understand what they needed and wanted. It's been mentioned earlier by others too, but we really took a day and whiteboarded what's going really well in Arkansas in healthcare and what do we need to improve. And so you'll see some of the focus areas then we decided to be collaborating on. We're looking at data and interoperability. We were looking at, red tape. How do we empower patients? and behavioral health integration. So I've already spoken to you about the health information exchange that we've really put all hands on, in and said, we're going to do this, and it's going well. The other thing I'm extremely proud about is behavioral health integration. So through this initiative, a not-for-profit Arkansas Behavioral Health Integrated Network was created and spends quite a bit of time, on a regular basis, having the conferences, educating and training individuals to feel confident and successful through those primary care practices. Next slide, please. A couple more stories here on this slide. So on the slide you see right there at the Fayetteville Police Department, as I had done, invited and hosted CMS staff and others to come to Arkansas, one of the areas we stopped, and this is just an example to show that it goes beyond just patient-centered medical home. It goes beyond the journey, but how do we engage the community, and how do we look at areas that are gaps that we can fill? So the Fayetteville Police Department was one of our stops on that visit, because of the fact that they have done a phenomenal job working with the University of Arkansas and deploying social workers out with the squads, and the improvements that they have done and the success that they have done by including those social workers. Now, where it started as some grants and pilots, the city of Fayetteville now funds those social workers and continues to grow that social worker numbers. The one on the bottom is an example. It's a conference where we had patients, providers, as well as payers at that table, truly hearing what having behavioral health integrated into a clinic how it changes their lives. And then the final one is looking for resources. This is very intense. It takes a lot of time. It had the convening, the facilitating, and things of that such. We started back during CPC Plus with all the payers in Kansas City, as well as Oklahoma and Arkansas. It takes us about the same amount of time to travel up to our Northwest Arkansas location. And we really have had some amazing opportunities to collaborate in training practice coaches, to look at resources and tools, because anything we can share and spread, we benefit from. We even are doing the 3 states. We're doing provider training and education together in these value programs. Next slide, please. Alrighty, on this next one, Donna, I'll share here. It just shows that some of the things that we've done in Arkansas to help with legislation. And Don, do you want to start and talk about it?
Sure. And so it's one of those things where, and I know it's, it could be a bit of a double-edged sword, but at times thinking about what are the things where we feel like we need legislation to be able to move something forward versus those times where we feel like maybe it's better to not actually have legislation. But we do think in these instances, it's been important to be able to talk a little bit about those places where we did feel like it was important. And one of those was, really after we had made the decision that we wanted to try to implement episodes of care, we felt like it was really important to be able to have, that sort of that buy-in, but I think also that decision as a key value strategy from, on behalf of the state, and really having that solidified as part of, some of our key legislation. And so, as part of that, we actually then went ahead and began developing the episodes, and then actually put them into practice, through the reforms, but then also had legislation to support that. And likewise with our patient-centered medical home, once we had the support of, our provider partners and patient community, we felt like, in order for this to really be something that we could implement statewide, that we also wanted to go ahead and then put that in place, much like Alicia had mentioned. It started out with, requirements within Medicaid, but then ultimately became a statewide requirement for participation within the marketplace, and really helped to be able to set the standard for what we felt like was important when it came to implementing patient-centered medical homes in Arkansas, both what it was and what it is, but also those components that we felt like were so important to the Arkansas model. And then Alicia, do you want to talk about the last two?
Sure, I'm happy to do so. I've talked briefly a little about our HIE and some of the requirements to participate in the value programs, but I'll spend a little bit here on the primary care spend. I'm very proud of our state. I know Arkansas Blue Cross and Blue Shield, since 2012, we've been measuring and monitoring, and in the back of the references here, we have the Millbank publication on how the return on investment and increase in primary care spend that we've been tracking. But there was recent legislation that was just passed that a working group, a committee has been established, and the report's due in April to the legislature. What we've done to this point is gotten a consistent definition of what is primary care spend, which clinicians are involved in that, and how that will be reviewed, and then a data structure fields for all payers to submit the data into our insurance department, and working along with the all payer claims database. One of the key things that we've really had to do, much of that work today in the files do not include the value-based payments. So trying to get some fields added into our all payer claims database files. So going forward, we ensure, because that's where we've really increased our money, is in the care management fees, the utilization, and the quality incentive areas. We can go to the next slide. And I'll pass it, John, if you start out on the challenges.
Thanks so much, Alicia. And I know we've told you a lot about many of the successes, as well as a lot of the things that have gone well on the journey. And there are many of those, but they were not without challenges, both then and now. And so we also wanted to make sure that we spent a little bit of time talking about those today. I think the first of which is payer participation. I know, and John touched on this a little bit with regard to the state of Pennsylvania, but much like, in Arkansas, we recognize in this case, we literally could not have done this without coming together as a multi-payer effort because, as you saw in some of the data, yes, we have a significant portion of the population, which is children, which, in Arkansas is in many cases covered through Arkansas Medicaid. But then we also have a large adult population, which is also covered through Arkansas Medicaid, but also a significant number of those patients, as well as those providers, are actually within the Blue Cross and other private payer networks. And so as we sat down to look at it, we said we knew we couldn't just focus on the children or the adults. We had to do it together. And so that's really what kind of led us to be able to then say, yes, like, A, do we want to do this? And B, if we're going to do it, like, the only way for us to do it is together. And so that was one of the important challenges that we had to overcome, which is how do we do that? Because as you'll see, kind of as we go through some of these other bullets, there's a lot of that we can do together, but there's also some things that we have to do separately when it comes to the legal side of the house. But inherent within that was being able to get the employer buy-in. Because, there are many things in Arkansas that we're proud of. And one of those is that we actually have a very thriving self-insured and small business community. And so as part of that, even though a lot of those do use, plans and payers such as, Arkansas Blue Cross Blue Shield to be able to take care of their members, there's a lot that also, are very involved in that, as small businesses or as self-insurers. And so one of the things that was so important in this was getting the employer buy-in to do this. And so as part of this, actually setting up, we had an employer-sponsored health council. And so we brought together the employers and talked to them about what's important and actually getting their buy-in and helping not just to move forward with the initiative, but actually helping to design, develop it. Like I can remember, some of you may be aware that, one of the sort of flagship employers that we have here in Arkansas is Walmart. And so, they were very involved in helping us be able to actually develop and support this initiative, as well as many of our other smaller employers within the state. And there's several others I think we can walk through, but Alicia, any that you want to add at this point?
I think you're good.
Great. Just a couple others that I want to hit on that I think are very important is, as you can see, there's simplification. There is a lot that goes on behind the scenes to make these things work, as I know, many of you on this call already know. But I think there's a lot when it comes to also then simplifying how we communicate about it. And so for us, because this really is a patient-centered initiative, we began with that, right? Where we sat down and basically said, what is the patient journey? And surprisingly, many people might say, oh, okay, well, I know clinically this is how you get from A to B to Z, right? And then a patient might say, well, this is how my experience has been. But one of the things that I think made us unique was that we came together and said, let's do that together, right? Like it's important to understand what's the patient's journey and perspective on what this looks like and how it works and where are those opportunities to be able to improve. But then likewise from a provider's perspective, because the providers, we heard very, very loud and clear, like they didn't want us telling them how to practice medicine, but they also realized the value in us coming together and really talking about where we could identify areas for improvement, and that would increase value, but also as well as the satisfaction within the healthcare system. So it was very important that we developed a common language and a common way for how we communicated, and really developed those initiatives together. And then, John talked about this as well, and it's just so important, but really thinking about like what are those metrics that are most important, because there's any number of, there's probably 100 different things during any particular visit that you could say, well, it'd be so helpful to know this or to know that, and that this particular value has this impact on this particular outcome. But at the end of the day, it was so important for us to say, what literally are those 3 to 5 right, that are most impactful, that we can come together and agree on as a community, that would best influence both the outcomes as well as the value for this particular approach to value-based care and purchasing. And then along those lines, thinking about the resources. One of the things that we realized as we started thinking about sort of what is it that we need from a data perspective, what do we need from the hospitals, many of them did not have the resources to be able to connect to the state's health information exchange. And so one of the things that was important for us was to say, okay, then we will help support that, right? Both through our public and through our private opportunities, being able to do that, to at least be able to get them connected and start to report like some of that basic admission and discharge data, but then ultimately being fully connected to the systems. And then the last thing I know that, has come up both as a challenge and then as a lesson learned was really dealing with some of those antitrust issues, because we definitely want to make sure, like I love all of our friends and colleagues that are attorneys. I am not one of them. I appreciate them, but I also know that, we also can't let things stand in the way, right? When we're trying to focus on, what's best for the healthcare system and for our patients and providers. And so, one of the things that we had to really spend some time thinking through was then what are those conversations and those things that we can do together, versus those things that we have to do separate. And through that process, we actually found out that about 90% of like the work in developing out these models can be done together, which was so great. The things that then like, how much are you going to pay and what's the payment going to look like? Those things all have to stay separate. And it was very easy for us to do that. But it also, I think, really pushed us to think about like, yes, there's a whole lot of things here that we actually do have in common. And that there is a way and a path forward for us to be able to work together to do that. Alicia, anything you want to add?
No, but I'll tell you what, if we can go to the next slide, and what I will do just for the interest of time, I'll go through these next two pretty quickly. So from a lessons learned, one of the things that I'll call out on this slide specifically, one of the challenges, if we don't have CMS at the table, it's difficult. And I think what we've learned is with these programs, we have attached and tried to align with CMMI as much as possible. But what happens is, like when we were in CPC Plus and the attribution for those Medicare members were in our share, our HIE. And then when we changed that program, those lives came out. Well, the doctors will go, well, why can't I see Ms. Smith anymore? And so I think that's been one of the challenges that CMS gets tired to hear me talk about. Like, can I please just have all your attribution in our HIE? So it's those type of things that really our providers and practices do their best work when they see everybody's patients, everybody's admission, discharge, transfer, and can work off of that. So you've got to conform to their practice and what they do in their clinic. And so that's been a gap or a lesson learned, certainly, is trying to figure that out. And many of these others we've already talked through. Dawn, is there anything before we go to the next slide that you want to hit on this? Okay, let's go ahead to the next one because we want to allow time for questions here. We'll do the same thing on this Arkansas successes. I think we talked about our collaboration, communication, our HIE. Practice participation, we've been very, very fortunate because the providers and the practices enjoy our collaboration that's coming together. I can't tell you how many times they thanked us. We actually have a recording of video from one of our learning and diffusion sessions that was a part of CPC Plus. We did a video and heard actually from the practices how these value-based programs have impacted their patients, their lives, and changed things for them as well. So I get excited, could talk all day long, but we're going to be very respectful of everybody's time, and we can go to the questions.
Mute. Thank you, Dawn and Alicia. Now we'll open the discussion to our committee members. At this time, PTAC members, please raise your hand in Zoom if you have a question for our group. Additionally, we will want to encourage our experts to ask follow-up questions of each other. Feel free to do so. You can signal that you have a question by raising your hand in Zoom as well. In the interest of ensuring balance across different perspectives and questions, we encourage experts to keep each response to just a few minutes. Okay, I think Krishna is first.
Yeah, excellent work. Really good to see have a light shined on these two states and the awesome work there. I was just curious to get sort of both thoughts on, just as we think about scaling this work nationwide, like any sort of reactions, thoughts, advice, if you like export this, to the whole country, like what would your advice be? So
I'm happy to take.
You go, Janice.
Yeah. Certainly as we approach our work, great question, so thank you. As we approach our work, that's one of the things we always have in mind, is how do you build scalability in processes? One of the lessons learned in our program was, especially our rural partners, our rural hospitals don't have a lot of resource in terms of being able to engage. And so as we build our programs, our education, it's really built about that framework of what's the balance between cohort-based learning, where you create opportunities for participants to learn from each other. And so again, they're not starting, from square one. And then, so cohort as well as individual. And, as we think about building methodology, everything that we build is with a lens of, okay, how do we start with this cohort? Then how do you take it to the next cohort? And so I think, and I would say that would be the same of how we approach the rural emergency hospital. So like running that technical assistance center for the country, it's very much about building repeatable processes. And then, so it's not every time you go into an engagement, you're starting from square one, whether it's templates or talking points or education. It's 80% of it is already prepared. And then you go in and you tweak it for the 20% that might be site specific or community specific. So going back to one of our lessons learned, was planning. How do you plan well? And part of planning well is how do you build scalability into that planning, and leverage, broad tools, broad think wherever possible, and then allow for the customization that might be needed within the program. So that's how I would answer that question.
Yeah,
Alicia?
and I'm very aligned with you, Janice, on those answers. And I would say healthcare is local, but when I say healthcare is local, it's almost down to the county level. So even within Arkansas, we couldn't do it consistently. We had to understand the different counties or different areas. And so understanding the community, what resources are the community, who are your champions in that community, and how do you get that playbook and adjust it for that community? So that's example I mentioned earlier with Oklahoma, Kansas City, and Arkansas. There's some things that Kansas City does really well. There were some things that Oklahoma does well, and there's some Arkansas. So when we all came together to get our best practices as well as payers, then we can kind of make a bigger impact and a faster impact with that work.
excellent, thank you.
Any other comments from our experts? Okay, Lauren, you're next.
Really excellent and exciting work. It's great to hear about the diversity of application. So across the day, we have heard consistently from our presenters that it's really important to have some kind of convener role that's financed. So, and then that infrastructure is involved in capacity building, trust building, most importantly, trust building and shared metrics across stakeholders, practice change, and then also really some of those integrated system improvements that it's no one's specific job to do, but having that kind of convener role is really important. So I'm curious, when you for the Rural Health Redesign Center, when you talked about the Behavioral Health Integration Network, how you're seeing those roles financed. I get to work with a lot of different communities, and sometimes the payers financing it, sometimes funding out of Medicaid waivers has financed it, sometimes it's another stakeholder. So I wonder if you could speak to the financing of that and the importance of that convener integrator role in the community.
Yeah, and Larry, if it works, I'm happy to help kick it off for Arkansas, and then I know others will have things to add too. But it's such an important question because yes, people often think like, oh, that work of like planning and convening, like people recognize the importance of it, but they don't often think about the fact that it's like that's people's time, right? That they're coming together to be able to do those things, but also the infrastructure, right, to support that. And so, for us, it was so critical. Like when we began this work here in Arkansas, we really had to think about like what can we do? Like we're kicking this off. This wasn't something that had gotten a lot of attention at that point. And so we actually used some of our own resources between like Arkansas Medicaid, then between Arkansas Blue Cross and Blue Shield actually to pay for some of that initial convening work, right? Like we brought in a consultant to be able to help us, think about sort of what does this look like? What are some of the different design features and options that we have to think about? And then, kind of once we got going, we said, okay, we need to be able to think about where we can, secure other funding because we couldn't, separately or collectively, like continue to finance this all on our own. And so thankfully at the time, CMMI had the State Innovations Model program, and particularly the grants. And so we applied, and thankfully we were one of the handful of states that were initially selected to do that. And so that brought a major infusion into the state to be able to then support the design and development and the implementation of that work. But I think the other part of it was also then, to your point, being able to think about how can we actually then change our payment models to support that. And so for Medicaid, yes, that was very much thinking about what state plan amendments, what waivers, what other types of authorities could we use to be able to then actually sustain, the work of these different models. And likewise, I know like, with our friends from, Arkansas Blue Cross and Blue Shield, it was also thinking about, okay, how do we sustain this, right? And thinking about through payer contracts, thinking about, the work with providers, as well as then what those reimbursement and payment models look like, because that was a big part of the change. And I think the last thing that I think is important to mention is, as you said, kind of that infrastructure piece. And, I think one of the greatest things that I feel like that we were able to do was to actually develop and then utilize like that shared infrastructure, like for data, for reporting, and so for a long time, like when, practices were reporting information to us, it was actually through like a shared portal that, from a payer perspective, we used together and we sent out our reports together, like through that. And so, because if we're asking them to do some of the same things, it didn't make sense to say, okay, we'll go over to this portal here and enter your information there, and then likewise go over here and do the same thing. So it was so critical that we be able to do as much as we could together, and would definitely encourage that as people think about sort of looking at, taking some of these models to scale across the country, thinking about where can we find that consistency and that shared infrastructure, so that way we're not asking providers or patients to do, to do the same things time and time again. That's just, adding more, waste and inefficiency to the system.
And I'll add, as we work through that, I think it's been brought up today about the trust and building the community and the trust, how if you're transparent, you understand where you're going. So throughout our different programs with CMMI, sometimes it funded conveners and sometimes it didn't. And so we as a state really rallied together, and I'll give you an example of show you how thick. So Dr. Richard Armstrong, that was with Quell Choice at the time, one of the kickoff meetings at that CMS was having for us in DC, he was not able to attend. And so I'll never forget this conversation where he told me, he's like, hey, Alicia, you're not just Arkansas Blue Cross, you're representing Quell Choice this time too for this trip. It was that we knew things we could talk about and could align with, and there were things that we couldn't talk about. And so it's truly building that trust and collaboration.
Any comments from our Pennsylvania team, John, Janice?
Yeah, I would just add similar as, good planning, funding for this work has to be part of the planning. So as part of the Pennsylvania program, CMMI recognized the need for the convener. And so that was part of the seed funding, was to create the RHRC. As we're doing our next generation work, funders like the Appalachia Region Commission, going to other types of funders that are willing to pay for that planning. And so, but it's good planning. It's a function that has to happen. Somebody truly, in order to advance it, needs to be there, serve as that convener, do all of the heavy lift, because again, there's a lot of work that goes into this. And then, as always has already been mentioned, the infrastructure and the planning and how to be efficient. And so just good planning. And then there are folks willing to fund this. And so our next generation work, a bulk of it is being funded by the Appalachia Region Commission as well as the PA Senate. So as we're continuing to evolve, leveraging that and then getting specific funding to advance the planning. And then certainly where we sit with rural health, we're hoping that our implementation will be funded by the Rural Health Transformation Plan specific to Pennsylvania. And in other states, I think, there's a lot of money there that, if planned well, can be leveraged to do this work.
Yeah, and I just would add too, I think long term, and it gets the little bit of the first question too. From a payer perspective, all the payers were not involved. So some of them were. I think making this work will, I think, work better if all the payers are involved. And obviously that includes the state and federal government. And then I think the savings, if you will, that you end up getting when this is done right, can be pushed back into some of that infrastructure payment as well.
Mhm.
And again, I think that ends up being all payer, including state and federal government. So, those are kind of, I think, looking forward opportunities and thinking how it could look.
But it's a great point, because all of our work is to get to the point of it being self-sustaining. So in order to do the work, you need that investment of capital, the financing mechanism. As I think you coined it, we need that up front, but the goal is then it's self-sustaining within the program. And to Dr. Bulger's point, it really is, the savings that are generated are then helping to fund the infrastructure and some of the platforms that are needed to be successful.
Great comments. Thank you.
Thank you. Lee?
Yes, Janice, like you had made a comment that providers really emphasized when you're doing your multi-stakeholder engagement and pulling out everybody's interest, that they were mostly interested in reliable cash flow, reliable revenue they can count on. And then you also commented about simplification, the need to easily understand the program. Certainly important when you get lost in the world of quality metrics. Just ask for you to comment further, and then everybody else, what actionable, concrete pieces did you find the provider community most emphasized in your stakeholder engagement that wind up being, kind of contracting avenues to design a program that brings everybody alongside?
Yeah, so I'm just going to answer with a little bit of illustration first. So within our first program, the Pennsylvania Rural Health Model, we had 2 payment mechanisms. And you'll see some of this language even in the AHEAD framework, again, because our work directly informed that. But we paid from the state side of the program or the commercial side of the program. We used something called virtual cap. Versus on the Medicare side of the program, the payment was truly facilitated in biweekly payments. We calculated a budget, we divided it by 26, and every 2 weeks the hospital knew what their check was going to be. Key lesson learned is that by far was far better than the virtual cap, because the virtual cap was still providing a lot of fee-for-service payment. So in the virtual cap, we calculated the global budget the same way, but the payment mechanisms were different. A lot of the payments still came through the fee-for-service claims with then true-up payments along the way. And our hospitals have really found, being able to count and know what that biweekly payment was going to be. So that's a key lesson learned as we iterate. It's like we truly want to know what our payment's going to be, and we don't want a lot of surprises at the end of the year, because there were some reconciliations that are done that based on market shift, you never quite knew what your final payment was going to be until after the program year was over. And so really trying to minimize all of that retrospective reconciliation and getting to more of a straight line approach to, and that's also for the payers too, be an accountant. So my formal training was an accountant. At the end of the year, you've got to do accruals and all of that. And so really moving away from the retrospective reconciliations, getting to a point where we know what our payment's going to be, and then we move forward. So any adjustments to the budgets would be made moving forward versus any type of a retrospective type of a calculation. So that's the thing that we've heard both from the plans and the hospitals is like, we want predictability. We want to know what the payments are, and we really want to move away from reconciliation. Also, I would say, and again, the trust, you've heard that theme, trust and relationships. Our hospitals and even probably some of our plans with there's still a lot of black box magic. We send stuff in, to us, the TA center. They don't necessarily know how. They generally know the frameworks. But really getting to just straightforward, this is how we calculate it. And again, doing away with the retrospective reconciliation, the market shift adjustments, and some of the things that we had in ours will just make it much easier for both payers and hospitals to understand, and then hopefully other partners. Because one of the things that we've recognized is, where our first focus is sustainability, preserving, but we recognize we've got to bring in primary care. We've got to align more holistically across the continuum of care. And so using easily understood and really reducing, I would say, the black box calculations that are happening that folks just don't understand. And to reiterate a point that Dr. Bulger made, anytime actuaries are needed to explain things, it becomes really difficult. So taking just a much more straightforward approach to calculating the fixed payment as well as the actual payment mechanism is really where we're landing.
Other comments?
I'll come at a little bit different area of the providers' feedback perspective that what we've heard. In the programs where we've offered the care management fees and allowing them the flexibility to meet the patients where they're at, we've seen some really good examples of success. Allowing those, when we talk about being, local care in the communities, one of the examples to this day that still resonates very well with me is that there was a physician that was having a lot of trouble with the care coordinator reaching the patients and getting to the patients and some of the different chronic conditions. So he set up next to his little clinic with some of the funds, a little gym. It wasn't too fancy, but it was a gym, and offered it to the patients for free. And then the care coordinator was able to wander through the equipment as the patients would come in and talk to them about their health conditions. Another one, very, very rural part of our state, very poor part of our state, the practice bought a washer and dryer because these children were going to school with their dirty clothes and it just didn't feel really good. But when the patients would come in to wash and dry their clothes, the care coordinators go in there and talk to them. So really trying to find those patients, meeting those people where they're at, and having the flexibility of those value dollars to do those type of very unusual things. The other thing I think a big discussion is around the burden of the quality measures. And we all talk about reducing the burden for the providers, and we can reduce the measures in our value programs. We support that. We're trying to get some systems up and create that efficiency and interoperability. But at the end of the day, for example, myself as a payer, I have over 120 quality measures that I have to report upon, be it state or federal government requirements. And if I have to report those, I have to get them from somewhere. So they might not be my value programs, but I still have to go get them. And so that's still creating that unnecessary or frustrating burden for those practices. So a couple different perspectives of feedback from providers, but it's different.
Yeah, and a couple things I would add to that. I think that was so well said. I think is really thinking about, much like to Lauren's question earlier about sort of what does it take to be able to do this work. We also have to think about that at the practice level. And so it was so important, one of the feedback some of the feedback we heard when we started doing some of this was, this is great that you're, paying for experts to come together and to be able to have these discussions. But, here in my practice, when I have to then actually implement this, like, I need tools and resources to do this too. And so it was so important that we did that, right? Like we actually invested practice transformation dollars in helping support practices to be able to do that work. That was one thing we heard loud and clear, like when, at the time there was a lot of pressure for us to say, well, adopt like the Medicare model or adopt the NCQA model or, whatever it was. you know, we heard loud and clear from our practices, like, hey, we want to do this. Like we want to be able to help, you know, figure out where there's value and efficiency, but we need some help and support to get there. And so that was a big part of then us hearing them and being able to say, like, yes, we can do this, you know. So I think that was a big piece of it. And I think the other part, and Alicia touched on this a little bit during, you know, our opening comments, is healthcare is local, right? Like, I mean, it is so much about like what we do and the patients we serve and our neighbors and our communities. And so the other thing that we heard was, yes, tell us what it is, you know, be very clear, you know, as Janice said, like, be very clear about sort of what it is you're asking us to do, but then let us also figure out how we do that, right? And so it's just so amazing. Like, I think about, you know, like between like the different groups and the patient councils and stuff like that, where practices would come together and say, this is how we figured out how we're going to do this. Like, I remember, you know, different practices would say, well, we have the blue team and we have the red team, and we'd have all these different sort of ways that they would then actually make it their own, which was so great because at that point, you know, just like any of us, right? When I have the opportunity to make something my own, it's more likely that I'm going to actually do it and I'm going to stick with it. And so I just offer that as you're, you know, thinking about, you know, both whether it's how to take to the scale or what is it that's important to the providers. I think it's definitely just like the rest of us, right? To be listened and to be heard, but also to be able to actually be part of the change and not just be sort of impacted by it as a downstream participant.
Well, thank you. I have a question myself. I was really intrigued by the prospective payment to the hospitals in Pennsylvania, where you allow them to craft a budget around it. I really think that's a fantastic idea. What about the physicians? Do they get prospective payments?
So not yet. So again, our first program was hospital specific, but one of the lessons learned that's coming out is we've got to figure out how to align this with primary care. And so as part of our next generation work, and I don't know if it's going to be a budget or if it's going to be incentive type payments, but that's certainly part of what is we're iterating with, you know, our stakeholders. Like, we know so much of this work needs to be done in the outpatient space with primary care providers sitting at the table. And so trying to figure out what that alignment strategy looks like and take that into consideration as we're building the budget. So, for example, for a lot of our rural communities, you know, they also employ the primary care and maybe even specialty providers. And so if we need more primary care within a community as part of that development of that global budget, should we be assessing what we're going to need within that community to get to an adequate level of primary care? And do we take that into consideration as part of the budget in order to recruit the providers to the community, cover all of that cost? So that's the type of conversation we're having. I don't have the answer to your question, Larry, specifically. But certainly as we iterate, we know it's got to be more than hospital focused. Our goal is to continue to stabilize, and then really big, I would say build a broader continuum payment infrastructure that's going to meet the needs of the community. I certainly would ask Dr. Bulger his thoughts on that. He sits at the table with me, engaging in these conversations. So anything you would add to that, Dr. Bulger?
Yeah, briefly, it's a great question because, and as Janice said, you know, it's a shortcoming of the original program. It was only hospitals, and I think you got to figure out a way to have, you know, clinically integrated network or something else that's baked into it, and then that organization, whether it's the same, you know, it's a hospital and it's CIN, or it's the hospitals and a larger CIN, because we have some statewide clinically integrated networks. Like, for example, the Pennsylvania Medical Society started a clinically integrated network statewide a few years ago. But there has to be a way to get the providers involved. And many rural hospitals don't have, the providers are independent providers that are, you know, they aren't associated with them. Which is sometimes different from large academic medical practices that might be in other places. So then figuring out and you have to bring those together. You can't have them separated. I think there's also a question to say, other types of providers in the community, whether that's physical therapy or home nursing or skilled nursing, all those, how do you wrap those in as well into one model? Because sometimes they're all under the same payment umbrella within the community, but many times they're not. But you really need all those people that are swimming in the same direction if you're going to make this work.
How about Arkansas? Any prepaid models there for providers?
Yes, we do. And so I can add on the value programs, we talk about you have multiple programs you have to coordinate. So we have our patient center medical home, our primary care first, like Blueprint Primary Care, but we also have our ACOs, our risk ACO products that are kind of the hospital contracts, and you've got your providers. And so we've really had to work hard to combine and coordinate those efforts. One of the things that we were hearing from the physicians independently in the primary care specifically is, hey, the hospital's getting that payment and I'm not seeing it in my practice where I need to get changes, or I need the funding in my practice to buy this or to do that. And so we just kind of worked through that with some transparency tools. So with that, each time we do a performance summary for the year, a thank you letter goes out to that individual physician, thanking them for participation in the program. It tells them their attributed lives. It tells them how much care management fees, as well as their utilization and quality incentives. So it's kind of a thank you note, but it's a report card too that goes out. And then 2 weeks after that, the similar goes to the CIN or the hospital with a whole summary and listing of all of them, of the performance and how that went or that participation. So what it did is it allowed conversation between the providers and the hospitals and how they can negotiate and coordinate that funding on those value dollars that they had earned. And, it's been I will tell you, I still to this day get a text when it's about value time about, hey, Alicia, where's my letter? Can I get my heads up? And so, it's definitely important for us to coordinate those dollars and to ensure that they are being used in areas of need. And so that's the pre-funding is really in the primary care area, but because so many of our clinics are being purchased by the hospitals around here, we're moving to that tipping point where more are employed versus not employed.
With some of those same services you just mentioned that you're able to provide by having a prepaid model is one of the major stimuli for prepaid concierge practices
Yes.
developing all around the country. And I know it's city specific, and it might not be as applicable in the rural areas of Pennsylvania, but certainly in the major cities, you could see where a model you have with prepaying physicians could actually provide the mechanism for a hybrid type payment model between prepaid value-based payments tied with fee-for-service payments with it. Any other questions from any of my other PTAC colleagues? Well, I guess we're going to get some time back. Excellent. Thank you, committee members. If you have any other questions for our participants, feel free to bring them. But I'd like to thank our 4 experts for joining us this afternoon for a robust discussion. You're welcome to stay. Oh, no, we're done. You can wait to listen to the rest of the meeting if you want. But at this time, I think maybe we go to an early break. And Lee, do we want to meet earlier after the break or keep it at the same time?
We're going to go to a standard 10-minute break and return earlier. Say 25 after.
Okay. You're all free till 25
Thank
after.
you.
Thank you, everybody.
Thank you so much for the
Appreciate
opportunity.
you.
Produced by the U.S. Department of Health and Human Services.